my topic for today is cryo and heat therapy in central airway diseases. So I'll be talking about cryobiopsy as well as electrocautery and laser and APC when it comes to central airway disorders. Before I start my talk, I would like to thank Dr. Bala Raju. Is he here? Okay, because he's helped me with his presentation for laser and APC. So as we all know, cryo is basically a technique wherein a cryoprobe is introduced via bronchoscope, and through this cryoprobe, the target tissue is attached by freezing, and then the target tissue is either removed for debulking purposes or lung biopsy purposes. For today's discussion, we'll be talking about how cryo is used for debulking purposes, not for ILD diagnosis. So by principle, there's a Joule-Thomson effect wherein gas is released at a very fast pace, and whenever this gas is released at an extremely fast pace, there is sudden fall in temperature. So whatever comes in contact with the cryoprobe tends to freeze. So earlier we used to have the first generation cryoprobes, which were basically the reusable cryoprobes. They used to come in size of 1.9 and 2.4 mm. But now what you guys will be using will be the second generation cryoprobes, which are single use cryoprobes, and now they come in the size of 1.1, 1.7 and 2.4. The game changer here is the 1.1 cryoprobe, because now this has enabled us to perform EBUS guided cryobiopsy, because this is the probe which can pass through your EBUS scope. The sole reason cryobiopsy is taken seriously in the past 1 decade is because of this. If you can appreciate the image on your left side, on the first image you can see that is how a transbronchial forceps biopsy is achieved. The second and the third depicts you how a cryobiopsy sample is achieved. You can see over here, you have the point. So as you can see, the sample is larger in size and there are no crush artifacts. And also there's an advantage that the cryoprobe can even target the tissue which is adjacent to it. So there is something called as frontal freezing and there is tangential freezing. These are the advantages which you don't have in a forceps biopsy. This is a direct comparison between how the sample looks to your pathologist when it comes to forceps biopsy. Relatively, when it comes to cryobiopsy, the sample is large and you will never get a pathologist writing you that the sample was insufficient when it comes to cryobiopsy. So there are different pathologies where cryobiopsy is indicated. Mostly it is ILD, but also it is used for peripheral lesions, and in today's talk we'll be talking about how it is used for endobronchial growth or tumor debulking. There are certain contraindications, so patients who are not fit for general anesthesia, patients who have hemodynamic instability, severe hypoxemia, and relative contraindication of patients having anemia. So the major risk involved with cryo is mostly bleeding and the patient can land up in hypoxia. So you need to follow certain precautions. Mainly is intubating your patient with an artificial airway, which might be with a rigid bronchoscope or an endotracheal tube or an LMA. There's also a need for an occlusion balloon, as Dr. Vishwesaran had showed, and you need ice cold saline when it comes to controlling the bleeding. So these are the artificial airways most commonly used. You can see there's a rigid bronchoscope, tracheal tube as well as the LMA. When it comes to management of oral anticoagulant, you need to stop warfarin 5 days before the procedure, and when it comes to clopidogrel, you need to stop 7 days before the procedure. There is a pre-procedure checklist that we follow. So it is essential that you have a CT of the patient, you have a complete blood count, coagulation profile, and also it is desirable that the patient undergoes a spirometry as well as a cardiac evaluation. What is new in cryo? There is something called as a spray cryotherapy. This is very much prevalent in the UK. We still don't have it in India, but as you can see, this is a non-contact therapy wherein cryo is sprayed over the target tissue, and eventually what leads is death of the tissue. So this is not used for debulking, but this is used for devitalization. So now coming to the heat therapies. So most of you must be aware about electrocautery. So electrocautery is basically applying high temperature for coagulation of the tissue, and we have different modes when it comes to cautery. There is something called as pure cut mode, and there is pure coagulation, and then there is a blend mode. So this is how the Arbat electrocautery tower looks like. As you can see, that is the electrocautery machine. And what we use is the monopolar electrocautery. So there is either monopolar or bipolar. We use the monopolar, and there are different accessories. You can see this one is an electrocautery knife. Then there is a hot biopsy forceps. Then there's a blunt probe, and most commonly used is the electrocautery snare. So here you can see this is a presentation. This is by Dr. Balaraju. So these are hot biopsy forceps which are being used for taking a sample or debulking the tumor. The only problem here is mostly your sample is charged, so it might not give you a diagnosis. When it comes to the electrocautery knife, this is used for tracheal dilatation, especially patients who come with tracheal stenosis. Now coming on to argon plasma coagulation. Now this is a relatively more advanced technique compared to electrocautery. The difference here is that this is a non-contact therapy, and argon gas is passed as a ionized gas from the probe to the target tissue. So this is how APC basically works. As you can see, there are different temperatures where the tissue reacts in different ways. So there is hyperthermia, devitalization, coagulation, and eventually there is carbonization. So we don't touch the APC probe to the target tissue, and what we achieve is basically death of the target tissue by heating. So you need to take care of how long you activate, what is the power setting, and how much distance you keep from the target tissue. So this is the most important slide when it comes to APC. So there are three types of APCs. There is an axial APC, there is a side fire, and a circumferential. So you need to understand these tools were designed for gastroenterology. So primarily they are used by the GI people. So they have a larger lumen. So you can see this is how the axial probe works. Then there is a side fire probe, and there is circumferential burning with the C probe. So this is a case where you can see how APC is working. So in this particular case, once debulking is achieved, there is some amount of bleeding seen at the target area. So here you can see the APC with the argon gas flowing out, causing coagulation to stop any superficial bleed. So APC is mostly useful for patients who are having any superficial or mild bleeding. So this is your APC. Obviously, there are complications when it comes to APC also. The most common is damage to the scope. So your scope can get damaged. You need to be careful with which probe you are using. And there are cases of gas embolism wherein this gas is known to then circulate to the vasculature. So in summary, this is used mainly for superficial bleeding. It is a non-contact hot therapy. You are advised not to touch the surface of the tumor, and always prefer low flow rates so that you don't damage the scope. And what is important with electrocautery, APC and laser is your FiO2 has to be less than 40% if the patient is on ventilatory setting. Otherwise you might end up in a, what would happen if you don't reduce the FiO2 below 40? You will have a endobronchial fire. Now coming to a more advanced technique, which is lasers in bronchology. So these are basically devices which send wavelengths, a single wavelength out, which is used for either cut, coagulate or ablation of the tumor. So there are different ways how lasers work. So here you can see this is a CO2 laser, this is a ARG laser beam, and this is the Nd:YAG laser. So there is a difference when it comes to vaporization, coagulation, and the penetration of the same. Obviously, for laser, it is advised that you always go for any endobronchial growth, not for any extraluminal growth. So there are different settings, and unlike the previous tools, you need to wear these laser glasses. You need a special setup wherein laser can be performed, and you need a team of dedicated technicians who've already used the laser. So this is Dr. Atul Mehta's rule for laser. So your maximum length of lesion should be 4 centimeter. The life expectancy should be more than 4 weeks, and the procedure should not last more than 4 hours. And as mentioned before, the FiO2 should be less than 40%. Similar, Dr. Dumont has 10 commandments for using the Nd:YAG laser. which also majorly revolves around using a rigid bronchoscope and keeping your FiO2 low. So what are the complications with laser? You can have either hemorrhage, you can have endobronchial fire, pneumothorax, you can have pneumomediastinum and so on. So we have only one case of laser. This is also from Dr. Balaraju. So here you can see this is a case of mid-tracheal squamous cell carcinoma. So if you can appreciate, there's a tumor over here, and this is how the laser comes into action. So this here is your laser tip, and this is eventually causing coagulation, carbonization, and also vaporization of the tissue. So this is the final image after the laser has been used for debulking. The advantage with these heat modalities is if there's any bleeding, you can control it right away. So now I'll move on to some challenging cases. So this is one case where you can see how cryo and heat therapies are used at the same time. So this one particular patient had an endobronchial mass in the right main bronchus. As you can see, this is the carina, and the right main bronchus has a polypoidal mass completely obstructing the lumen of the right main bronchus. What would be your next favorable step for this? Can you appreciate the type of the mass? It's a polypoidal mass. You would want to go ahead with a electrocautery snare. So here you can see how the electrocautery snare is being put around the mass to debulk the tumor. And also this is the cryoprobe. You can see the cryoprobe is being activated. As explained, the cryoprobe is coming in contact with the target tissue and leading to freezing of the tissue, and this whole mass is being removed en bloc. So this turned out to be a case of endobronchial leiomyoma. As you can see, the size of the tumor is much larger than expected. So another very interesting case, this was a 22-year-old female who was being treated as bronchial asthma, and she came on BiPAP support. She was requiring high levels of oxygen, and her CT scan showed some endobronchial luminal compromise. So we went ahead with a check bronchoscopy, and as you can see, the trachea showed a pinhole stenosis. So the patient was in respiratory distress because of this pinhole stenosis over here, and we went ahead with a electrocautery incision as well as dilatation of this tracheal lumen. So as you can see, this is the dilated trachea, and post the dilated trachea, you can see there is also a compromise in the luminal measurement for the right main bronchus and the left main bronchus. So the patient had multi-level airway stenosis. So we planned for a silicone stent installation. So this is a fast forward video, if you can appreciate, that is the silicone stent being put inside, and this particularly is the CRE balloon which is being dilated to get the silicone stent in its right position. So eventually post this procedure, the patient was completely asymptomatic. Patient was completely off BiPAP support, and here you can see this is the CT image for this particular patient. So the tracheal stent is in its position. So this patient was followed up for 12 months with the stent inside, and this is how the stent was visible after 12 months. And eventually, yeah, I forgot to mention. So the biopsy for this patient came out to be endobronchial tuberculosis. Patient was started on ATT. After 12 months of ATT and thoroughly following up with the situation of the stent, we decided to remove the stent after 1 year. So here you can see a Y stent being removed, a relatively challenging procedure for me also. I've done it only once. So for PGs, you need to see that you need to grasp both the ends of the stent not just one side but both the ends, squeeze it and then rotate the stent, because Y stent in itself is supposed to take the shape of the trachea. So it's a relatively challenging task, but I had some guidance from Dr. Balaraju, and eventually we were able to remove the stent. So this is how a stent looks after 12 months staying inside. And these are the images after 12 months post stent removal. So I've been following up the patient for the third year now. So you can see there is the tracheal lumen is almost patent. There is some damage to the cartilage because of tuberculosis, and we have complete patency of the left bronchus, and the right bronchus is still patent enough so that the patient can do all her regular activities and does not require any oxygen support. So this is another case of tracheal dilatation. So most common use for heat therapies in Indian setting is patients who have been intubated either in the wrong size of the tube, wrong pressure of the cuff, or patients who have a very high tracheostomy and they come to you with this subglottic stenosis. So the electrocautery knife here is being used to give incisions, and once these incisions are given, we use a CRE balloon to dilate, and as you can see, post dilatation you get a complete lumen patency. Then there are certain cases where patients have already undergone stenting, patients have undergone dilatation, and they are called as either a stent failure or dilatation failure. And these are the patients whom nowadays we choose to go ahead with a Montgomery T tube. So this is a T tube wherein you can see there are two ends inside and there is an end outside. Advantage here is that this works as an anchor so that the stent does not migrate. And in our experience with almost 4 cases now, patients are very much comfortable with the T tube. And it's around 6 months when we decide to then remove the T tube. So here you can see this is bronchoscopic end showing how the proximal part of the T tube is placed. And eventually once the T tube is inside, this is how it appears. So you can see we are going from proximal to distal, and what you see up on the ceiling is basically the limb coming out for the patient to breathe. I believe this is the last case. So we had a patient who came to us already intubated on a 7.5 endotracheal tube requiring 60% FiO2, and if you can appreciate, this was the bronchoscopy image. So this is the lower part of the trachea, and you can see almost 90% of the trachea is already compromised. So this is Dr. Rajurkar's case. Is he here? So the patient on the CT scan had a tracheal mass at the lower 1/3 of trachea, almost compromising the tracheal lumen and completely blocking the right main bronchus. So we went ahead with a VV ECMO. So this is the first time in central India that a patient was put on an ECMO only for a procedure. Because of the high risk of bleeding and a risk of death on table, we convinced the patient to go for a VV ECMO. The patient was put on ECMO, and within an hour's time we started with the procedure. So a rigid bronchoscopy was performed, and as you can see, this is how the trachea was looking. So there was hardly any air passage going to the left lung, and this is why the patient was requiring more than 60% FiO2. And like the previous cases, an electrocautery snare was used to debulk this particular mass from the right side, and then this was followed by cryoprobe. So you can see the cryoprobe was used to debulk this tumor, and almost 6 centimeter of tumor mass was removed from the trachea and the right main bronchus. And in the same seating, we went ahead with a tracheal dilatation. So this is how you can see post dilatation we had a silicon metallic stent, because she most probably, and she did eventually, turned out to be a malignancy case. So this is how the procedure was done, and the patient was weaned off ECMO in the next 12 hours and weaned off ventilator in the next 48 hours. So in a period of 72 hours, the patient went on ECMO, underwent biopsy, debulking, stenting, and patient was off ECMO to go back home again, and now the patient is being followed up for chemotherapy. There's something called as cryoablation. So at times when you have a slow growing tumor, you can just touch the cryoprobe, freeze the tumor, and then let it thaw. You can freeze thaw, and call the patient after 2 weeks to just see that the tumor size has reduced. But this can be done only in non-critical cases. Also, your endobronchial challenging cases might be blood clots. So cryoprobe is very helpful for removing blood clots also. So this is a case of blood clot. This is our study of 10 patients who underwent dilatation as well as stenting. This will be presented at APSR Taiwan this year. So for comparison, you can see that these three, cautery, APC and laser, are all hot therapies and cryo is a cold therapy. Amongst these, electrocautery is contact therapy, whereas APC and laser are non-contact. Cryo is also contact. And your major issue is that there is a risk of fire in cautery, APC and laser. There is no risk of fire in when it comes to cryo. And for hemoptysis control as well as for any stricture that can be there, you need to be careful with all these three tools. So hot modalities are an integral part of IP, and electrocautery is good enough for most of the cases. You need not go for an APC or a laser. Electrocautery will do the job in almost 90% of the cases. And for superficial lesions, APC is the best modality. You always have to evaluate the risk and the benefit. Your training with rigid bronchoscopy and balloon dilatation is very useful. You should have expertise in intubation and the rescue techniques, and patient safety is most paramount. So for every case that I've shown, there are 4 or 5 cases which we decided not to do when it comes to patient safety. So you should know when to do and when not to do a procedure. So as chair of media committee of WABIP, I invite you all to join WABIP. So this is the largest body of interventional pulmonologists. We are more than 11,000 members across 60 countries. So you can go to wabip.com, or if you are a member of IAB, that is Indian Association of Bronchology, you can join through IAB. There's a official WABIP IP training going on in Istanbul. It's a 3-month free of cost training program which you can apply for. So for that you can go to wabip.com. And last but not the least, I would like to thank my mentor, Professor Gasparini, who's taught me and who's been guiding me over the years. I am thankful to Kedar and Balaraju. I believe they are somewhere outside, and they have been with me throughout this journey. We have a big IP family now. So earlier there used to be few IP people, but now with every year there are more conferences, more people coming from across the globe. And last but not the least, most of these cases were performed over patients from my mentors, seniors and colleagues from Nagpur. So thankful to Vidarbha Chest Association. That is how we are officially, but unofficially we are just a family of pulmonologists. So that's how I get my work. Thank you for the patience listening.